Hello, everyone, and welcome to the PFCC Partners June workshop. We are very excited to welcome our friends from Connecticut Hospital Association to talk about co-designing at the sharp end. They will be giving us an overview of their patient family engagement structure that really includes a statewide patient family advisory council and how they have continued to move forward and spread innovation throughout the state. Today we have with us Ellen Crow and Dr. Mary Cooper from Connecticut Hospital Association, as well as Donna Druin, who is a patient family advocate at Middlesex Health. I am Lindsay Galley. I'm the Director of Education for PFCC Partners and will be facilitating today's workshop. We are Zoom in today. I'm sure a lot of you are becoming more and more familiar with Zoom and meeting online, but I just wanted to provide some quick tips and tricks for using our meeting platform for today. First of all, if you have any background noise, you can find the mute button by hovering over your screen and finding the toolbar. On that toolbar, you'll be able to find the mute button. You'll also be able to find the video button, start and stop video. So if you would like to show your smiling face like I am, you can do that as well. We will have some time for questions and answers at the end of the session today. So throughout the session, if you have any questions or comments for the presenters, you can put those in the chat box, which I see a lot of you have already found. You can also find that chat box on the toolbar as well. If you would like to speak up and ask a question during our Q&A at the end of the hour, you can also use the raise hand function, which can be found if you click on participants, and then you should see a little small blue hand that says raise hand. So you can use that during our Q&A session at the end of our time together today. Before we get started, I wanted to do a quick poll to see who is in the room with us, and I passed our hosting off to Laura Jackson to manage mutes. So Laura, would you be so kind as to open the first poll? It's titled June Workshop Audience Roles. Okay. Yes, you can see it. Thanks, Laura. So please just check as many boxes that fit who you are. What is your role in healthcare is our first poll question. And we'll leave that up for a minute. And I see some of you posting your roles in the chat as well, so thank you. All right, Laura, if we have a good amount of responses, if we could share the poll really briefly. Awesome. So it looks like we have a lot of patient family advisors and patient family caregivers, a good amount of leadership, which I'm excited to see because our friends at Connecticut Hospital Association will be talking a lot about buy-in for leadership support for their patient family engagement efforts. Great. All right. Great to see you all here. Thank you for joining. And without further ado, I would like to introduce our presenters today. First and foremost, we have Donna Druin, who is a patient family advocate for Middlesex Health. We also have Mary Wright Cooper, Senior Vice President of Clinical Services at Connecticut Hospital Association. And finally, Ellen Crow, Director of Clinical Excellence and Care Redesign for Connecticut Hospital Association. So I will let you all take it away.
Thank you so much, Lindsay. This is Mary Cooper. I'm going to kick off, but you're going to hear from all of us during this presentation. I am just delighted to be here. It's a beautiful day in Connecticut today. We are just on the other side of our COVID surge in Connecticut. We're not going to talk about that today, but if you come back and hear from us in the fall, you can hear how we managed to be patient-centered, family-centered during our COVID activity as well. Lindsay, if you can advance it to the next slide, please. Thank you. First of all and foremost, none of us have any conflicts of interest to declare. Next slide, please. And our objectives for today's talk are four. First of all, we want to describe to you how to engage your Patient Family Advisory Council, if you have one, to partner with hospital operations and impact culture. And we started off with that objective because we really feel strongly, the three of us, about empowering Patient Family Advisory Councils so that they are co-designing with hospital operations. And we're going to talk about what that means in just a few minutes. Our second objective is how to identify how to select a Patient Family Innovation Unit. We're going to talk about what those are and how you can use them to further your objectives to enhance patient and family-centered care. We're going to demonstrate how to trial and test healthcare innovation utilizing a PDSA model and develop a roadmap to partner with patients and families to assist you in making that transition. I love this, this at the bottom that Donna provided us. I've already shared it with a number of people. In addition to my role at the Connecticut Hospital Association, I also am the program director for healthcare quality and safety at the Jefferson College of Population Health. And statistics are patient stories with the tears wiped away. How powerful is that? I had a student this past semester who graduated who told me in his organization, they start with patient safety stories and patient stories every day because their mantra is no data without stories and no stories without data. Next slide, please. So first, let me just briefly talk about the Connecticut Hospital Association. I've been here for 8 years. And my background is in internal medicine, but for the past 30 years, my passion in my practice has been in healthcare quality and safety. The Hospital Association has been there over 100 years, and we represent hospitals in Connecticut and partner with other groups around the state so that we partner with long-term care associations, with healthcare at home associations, with all the state agencies, and with all of the patients and families across our state. So I think that what we've been able to do in Connecticut is to be what we call an all-in state. And what does that mean? That means that anything we're doing, the expectation is that we all participate. People can't opt out. And that's been crucial to the success of the project you're going to hear about over the next 45 minutes. Next slide, please. So this is, it says polling question number 1, but actually Lindsay beat me to it. So this is polling question number 2. Does the hospital with which you're affiliated have a patient and family advisory council? And Lindsay, if you can pop that up, that would be great.
I'm actually going to ask Laura if she could bring up that poll. She is the host now. Awesome.
Here we go. Thank you. And we'll wait for a few minutes. For those of you who are not from a hospital, think about the hospital at which you get your care, and whether you know if they have a patient and family advisory council. We'll wait for a minute, and Laura will pop up the responses. Well, that's the good news, is that it's more than a majority, but the bad news is it's not 100%, because it should be 100%. We're going to talk about why over the next few minutes. I'm going to turn over the next slide to Donna Druin, who helped me start this journey about 5 or 6 years ago. Donna?
Thanks, Mary. And congratulations to those of you who already have a PFAC If you are making progress collaborating with your hospital team, more kudos to you. You're already on your way. I know in other PFCC meetings, we cross-share new and interesting ideas and look forward to continuing to do that. And because you don't have to reinvent the wheel over and over, that's exactly why we're here to talk with you today. This isn't a contest, this is a mission. And Mary has been an amazing leader in this regard. I simply ask that you remember the most important gift an individual has is their personal experience. And the most valuable thing a person can do with that experience is to share it. Slide, please. I lost my cousin at age 59, my aunt, my mom, and my uncle, who is pictured here, all within 4 years. And each incident brought more and more concern for the capability and the communication issues between hospital staff and family. He, along with the others, were my inspiration to tell the CMO through my tears, you kill people here. We can do better for our patients and our families. Next slide, please. It wasn't long after that exchange that I was invited to become a founding member of the hospital's PFAC, which I led for 6 years. And from the beginning, the committee recommended and collaborated with hospital staff and management to make tremendous improvements in patient and family hospital communications. With 2 and 3 years under our belt, lessons learned were many, but key was that working together with our hospital team members produced excellent results. And this was too good to keep to ourselves. And we felt that if every hospital did what we were doing, lives could be saved and engagement could be achieved from all hospitals. We could all learn from each other across the state, advocate for PFAC in every hospital, improve results, even while tightening budgets, through innovation and sharing and using patients and families as part of the solution, especially with new and more healthcare measures focused on patient experience. It was simple. It only required patients and family to participate in solutioning. And we knew that it was the right thing to do. Slide, please. You've heard the saying, some people see things as they are and ask why. I drink things that never were and ask why not. There was one place that could help drive this wild idea, an idea that was too interesting to ignore. Make patient voices matter. And with a brief and exciting introduction, Mary Cooper listened to the potential, the accomplishments. She reviewed materials, made them available to all hospitals. And when she asked if we could help design the Connecticut PFAC, 4 of us tripped over each other, eager to share the patient's perspective of a statewide PFAC. The enthusiasm was contagious, and CHA was on board with the idea. Making it happen? Well, that's another story, and we'll let Ellen walk you through how that was accomplished. Next slide.
So thank you very much, Donna, and welcome to everyone. I'm going to be happily taking you through the next bit of the presentation and talk about the building of that statewide PFAC, just to kind of give you some perspective, because the innovation project for patient family innovation units actually was driven out of a statewide PFAC. And I'll talk a little bit about that and how that kind of transpired. But the Connecticut Hospital Association has a patient care quality focus, amongst other things, and we are really focused on high reliability. We started a high reliability journey back in 2011. Was very successful, and all of our hospitals in the state of Connecticut joined us on that journey. This was just a natural progression from high reliability, really engaging patients and families to really help us in that journey. We actually launched, thank you to Donna, and certainly with Mary's oversight and drive, a Patient and Family Advisory Council Planning Committee. And they were going to really put forth ideas and recommendations to one of our board level committees at CHA, which is called the Committee on Patient Care Quality. So the Committee on Patient Care Quality asked this group from across the state with representatives to tell them how they could design a patient-directed care initiative at a statewide level. And so next slide, please. So in 2016, the work of that task force that really came together to develop recommendations to our board level committee completed 3. And that was in October of 2016. And in November of 2016, our Board of Trustees for the Connecticut Hospital Association, which has many of the CEOs, which is really an important aspect, driving and embracing patient-family engagement and the things that you're really wanting to develop at the highest level of the organization. We certainly got that buy-in out of our Board of Trustees and our hospital leadership. That was approved, a patient-directed care initiative with the recommendations from that committee that was really the brainchild of Donna and Mary Cooper. Next slide. The recommendations that came out of that PFAC planning committee really was to implement a PFAC or similarly named structure at every hospital in Connecticut. We felt it was really important to have the patient family voice front and center in all of our Connecticut hospitals. So that was the first recommendation. The second recommendation was to implement a statewide PFAC to get representatives from each CHA member hospital in Connecticut to be at the table along with their patient advocates to really talk about how to drive culture change. The third was to create a transparent scorecard, and we really focused on HCAHPS, looking to see how we could move HCAHPS from a statewide perspective down at each of our hospitals. Next slide, please. So the critical details really was to gain that hospital senior leadership buy-in. Really very critical because we knew that that commitment was going to be essential all the way down throughout the organization, down to the frontline staff. Having a culture of embracing the patient and family voice was really essential. Building the statewide structure was really a critical moment for us to really bring people together around a table. Recruiting for co-leadership was an important aspect. We wanted not just a member of hospital leadership to lead this team, but we also wanted a patient advocate. So we were looking for that right from the beginning. Also ensuring that there was a tight connection to the individual PFACs across the state was very important, and engaging hospitals who haven't begun the PFE journey yet, the people who didn't have a patient family advisory council. How are we going to engage them and really drive the culture within their organizations to create such a thing? So that was a really important aspect. Next slide, please. So our PFAC structure, we actually launched the statewide in April, and I know it was April 4th, 2017, because it was a really exciting day for me, along with many of the other individuals in the state of Connecticut. We had staff and patient representatives from all of our hospitals in the state that were invited to participate, whether they had a PFAC or not. We wanted them at the table. It had membership of hospital representatives and patient family representatives. We asked each hospital in our state to send a hospital leader or someone who was responsible for patient family engagement in their organization, along with one individual patient or family who received care at their organization. It was co-chaired by a chief nursing officer, and it remains that to this day. This is a very robust group. And a patient advocate. Next slide, please. So polling question number 2, or actually to Mary's point, polling question number 3 actually, does your state have a patient and family advisory council at the statewide level? And if we could bring up that poll, that would be tremendous.
Thanks, Laura. Mhm.
Great, we'll just give you another few seconds here and then we'll show the results. Great, wow, that's a very even split. So 33% across the board. So thank you so much. Very interesting. So next slide, please. So the first thing that we did on April 4th, 2017 was we created a mission statement and our mission, and there's some pictures actually from the inaugural meeting of our statewide PFAC. Our mission was to elevate the voice of patients and families to drive a culture of patient-centered care. Next slide, please. So the benefits of a statewide PFAC, and certainly the 33% of you that have a statewide PFAC, hopefully you will agree with these as well as have some of your own, I'm sure. But hospitals can learn from each other. The sharing and the peer learning is a really important aspect of the hospital association. And we felt that it was really important to have other people learn what each other's doing and not to reinvent that wheel. So definitely the learning, as well as high-level PFACs can mentor others. You know, there were some PFACs that were functioning in the state, but weren't functioning at a robust level. Lots of different different aspects of whether they were engaged or not engaged. Some were struggling on how to find projects. Some were rubber stamps for operations, which really disengaged our family advocates who are dedicating their time. But those sharing of best practices, really, really key. We identified those in this statewide PFAC and had presentations from people who are doing really, really well so that we can inspire others. And certainly we can all learn a lot from individual journeys. Next slide, please. Some of the challenges. Some of our hospital PFACs, like I just talked about, are much more evolved than others. So that was a struggle because we weren't all on the same level playing field, so to speak. Each hospital possesses a unique culture. We know that from our own organizations. We take care of different populations, so we certainly needed to be respectful of what individual hospitals brought to the table, and we were. And there it is, every community has different needs, and they also have a much different grouping of patient-family advisors. What we did find, and our biggest challenge, and that comes with what we're presenting about today, was it was really difficult to drive culture change in hospitals from a statewide perspective. We were, 1,000 feet, and we really needed to get down to boots on the ground, so to speak, to really drive culture change within organizations. So initially, we really wanted to see if we could drive it from the statewide perspective, and we learned a lot. And this initiative came from the statewide PFAC out of the frustration that we weren't perhaps seeing the results that we wanted to see. So next slide, please. We specifically targeted HCAHPS. I think you talked about that. So we reviewed HCAHPS from all of our Connecticut hospitals. We shared best practices. We wanted to see if we could move them. We selected specific domains for improvement opportunities. We had guest speakers, very engaged around moving these HCAHPS. But like I said, we struggled to see improvement at the hospital level. So we realized we really needed to dig deeper. and get closer to that sharp end. You know, because patient and family engagement is made up of 1,000 different touches and conversations and interactions each and every day. And so we really needed to dig deeper and get closer to where our moments were, so to speak. Next slide. So our statewide PFAC vision really is very patient-centered. We needed to have the patient and family voice, and you could see that from our mission statement, really at the focus of everything that we talked about. What value were we bringing to patients and families and the community that we served? Next slide. We really wanted to look at and did a lot of research about patient care design models, and there's a lot out there. It started way back in 1986, just to kind of give you a flavor for how long we've been talking about what's the best patient care design model with user-centered design. Then we evolved to participatory design, which was in 1993. It really further kind of built a process for that the user, the end user, was really important to think about when we were creating things. And then patient-centered co-design. And that utilizes the theories of participatory, and it considers the needs of the patient, and it embraces that active participation. So next slide, please. So although we loved the patient-centered co-design, and this methodology is really from the Institute for Healthcare Improvement, we loved co-design. We felt that from an organizational perspective, when we really went out across the country and started talking to people about how are you utilizing the methodology, it was very much at the organizational macro level. So really it was when large decisions were being made at an organization. So for instance, if I was going to start a new service line, I'd want to have patients and families at the table when we were thinking about what service line we were going to be launching, perhaps changing all of the hospital menus, something big people were utilizing co-design for. But we know that all of those thousands of interactions happen each and every day, and that's where patient and family engagement comes from. So we wanted to bring this co-design process down to the blunt, down from the blunt end into the microsystem. Next slide, please. So the Connecticut Hospital Association really wanted to build on the ongoing success of patient-centered co-design, but we wanted to utilize those design principles down at the sharp end or the microsystem. And that is in individual hospital departments where the care is being delivered. Next slide, please. So patient-centered co-design at the macro level, where we really aspire to be is in the blue sections where there's a self-care system or individual caregiver patient system, and certainly into that microsystem. So we really wanted to really get closer to the bullseye, so to speak, of engaging patients and families. So next slide. The micro level brought us closer. This is the clinical microsystem where all those interactions happen. And so we felt good about moving our decision-making processes closer to the patient and family. Next slide. So an innovation unit. An innovation unit is not new. You may have some. But an innovation unit is a department within a hospital that trials process improvements to determine the value of improvements for the organization. And I have to tell you that innovation units, and I'm going to give you some examples of very, very robust innovation units that are across the country. They are driven by frontline staff. They look at the work that they do each and every day, and they challenge their status quo. And they design and test and trial new ways of doing their work. So innovation units are very popular. I happen to be a huge fan of innovation units. So certainly I was really excited when the statewide PFAC really wanted to get down to the sharp end because that's where I really feel comfortable. Next slide, please. So what is a patient family engagement innovation unit? Well, a department within a hospital that trials patient-centered care process improvements to determine the value of the improvements to the organizational culture, focusing on the patients and their families. Specifically, what value is brought by each and every individual process or behavior, what value is brought to the patients and families that we're serving. So next slide, please. So our very first innovation unit model that we looked at actually was from IHI as well. And many of you have maybe participated in the Transforming Care at the Bedside program. It was very robust, launched in 2003. It was in partnership with Robert Wood Johnson. We have a couple of organizations in Connecticut that participated in that collaborative. And so we really looked very heavily into what really worked in that particular innovation unit model. It's the first innovation model that we could find, and it was brought to us by TCAB. Next slide, please. Penn State has an incredible love for innovation. They have several within Penn Medicine. Sharp Grossmont Hospital out in San Diego also really embraces the innovation unit concept. So we took a look at them and how they pilot new ideas and move them into the hospital-wide structure, because we really want to build things in the PFE innovation units, and we wanted to make sure that we had the best practice on how to spread these innovations, not keep it in the four walls of the innovation units. Next slide, please. Partners is another big organization, healthcare system that are very committed to innovation units. They have 15 innovation units at Mass General alone. Really very committed to driving change. And they're really firing up their frontline staff into being really cued into what's working, what's not working, what's broken, and really fixing a lot of the issues that they have within their organization. And it's really set some fire in the belly for innovation and for PFE, although their innovation units aren't focused on that. And they don't have patient families at the table, but they do work through their patient family advisory councils. So next slide, please. So the bad news and the good news. So, you know, we are really committed to making sure that we're bringing best practices into the Connecticut Hospital Association. And the bad news was that patient family engagement innovation units, the way that we had thought that they should look, was not out there. And that was the bad news for us, because we couldn't steal savagely from other people. But the good news is that we couldn't steal savagely from other people. And that really excites me, because I love innovation. And so that was good news, that we were actually able to develop something that was perhaps new and different, and we could share just like we're sharing today. So next slide, please. So I love innovation as an invention that was actually implemented. You know, if you think about the US Patent Office, how many brilliant ideas are on the shelves or in a database somewhere, not really taking off. It's still an invention. It's just not embraced. And so innovation is actually taking that invention and actually implementing it. So we looked at evolutionary and revolutionary. So evolutionary is really building upon the good things that you already have. And that is like the iPhone. If you think about it, how many renditions of the iPhone do we currently have? So that's an evolutionary innovation. Revolutionary innovation creates a new work environment and impacts the culture of care. And certainly we gravitated revolutionary. Revolutionary examples would be like the Model T. You know, we no longer killed horses traveling from California to New York, right? So we really wanted our teams, and you can see the quote on the bottom, we wanted our PFE innovation teams to lean forward. So when you lean forward, you innovate, you create, you really want to build something that's going to be of value, that's not out there yet. When you lean backward, you wait for other people to build it, and you're leaning backward and you catch it, and then you implement it within your organization. So when you lean forward, you're being Googled. When you lean backward, you're Googling. And certainly our teams were really inspired, and we wanted to be Googled, so it was great. Next slide, please. So the goal of PFE Innovation Units was, through this co-design methodology, medical surgical staff and patient advocates would seek to change and increase the culture of patient family-centered care within that microsystem and embed processes and behaviors that would support and sustain the culture. Now, two key words in that sentence, and I've underlined them both: processes and behaviors, because it is not all about process. Patient-family engagement is a lot about our behaviors, how we treat individuals, how we connect with them, the relationships that we build. And so we wanted to look at not only what we do, but how we did it. So next slide, please. So PFE Innovation Units, designed after healthcare innovation models, which we talked about. We wanted to do it on med-surg units because we wanted a really good blend of patient populations. We identified a medical surgical patient care area to participate. We started with the chief nursing officers. After getting approval by the CHA board, which comprised a lot of our CEOs, we went and did a presentation of what our vision was to not only the Committee on Patient Care Quality, where they oversee patient-directed care. We took it to the chief nursing officers, and we said, this is voluntary. We'd love you to offer up a unit within your organization. Are you willing? And so we also wanted the Patient and Family Advisory Council within each of those organizations that volunteered to form a partnership with us. They would be tight partners with the unit that was identified because they were going to be at the table for each and every decision and discussion. So processes were trialed and tested. We utilized rapid cycle methodology within that microsystem. We'll talk just a moment about that in a little bit. And the results and the processes tested were shared with the hospital senior leadership, along with the CHA statewide Patient Family Advisory Council, because remember, this was their birth child. And the successful processes and human behavior changes that were identified, trialed, tested, and we had data to show that worked, we would then bring them out to additional units within the organizations and into that macrosystem level. PFE Innovation Units, we stress this with the groups that were really thinking about joining the collaborative, the PFE Innovation Unit Collaborative. Think of a unit, think of how open they embrace change, think about your frontline leader. Frontline leaders are absolutely critical in this process. And so think about the unit that you would think would really be a great fit for this project. So next slide, please. So here's another polling question. If you work in a hospital or if you were involved in a healthcare entity, can you think of a unit or a section of your environment that embraces innovation that would be successful in this type of model? I'll just give you a couple of moments to think about that. Okay. Cannot wait to see the results. So 56% of you. Yes, that's great. That's great. And if you really think about, kind of the concepts that I talked about, what the unit would look like, there's things that probably pop up in your head. What kind of leader? What are the staff like? What are the dynamics like? How do they treat patient and families currently? And would they like to take that one step further? Because this is patient-family engagement on steroids. So next slide, please. So these are the organizations, and we capped it at 8 because it was a lot of resource that we gave these innovation units in cohort 1. So we did this project in cohorts. So 8 hospitals participated. You can see the star, that's where we're located in the state of Connecticut. There are all of our hospitals in yellow. And so CHA was kind of in the middle of the pack. And so those were the 8 hospitals that participated. Next slide, please. So hospital PFAC activities prior to PFE innovation launch. So here's the thing. If we are going to be really true to the co-design methodology that, you know what, nothing about me without me, which really was our mantra, we had to go to the patient-family engagement or patient-family advisory council at each of these 8 hospitals, talk them through the process, and ask them what they thought, and if they thought we were on the right track. And so prior to the launch, we got their blessing. We gave them the full concept of what our vision was. We took them on a Gemba walk. A Gemba walk is an observational walk up to the innovation unit. We wanted their perspective. Anything jump out at you? How do you feel, how do you feel that the environment is? Is it a welcoming environment? They gave us a lot of feedback on not just the environment, but how they felt that staff welcomed them when they came up to the unit. We asked the frontline leaders, please don't tell anyone that we're coming. We want to go up on the unit and see how strangers are greeted. Then we did a thorough brainstorming exercise, and it comprised of 4 questions, but the one that I really wanted to point out was thinking of an exceptional experience. Hang on one second, sorry. Thinking of an exceptional experience that you or one of your family members have had in a hospital or other healthcare setting. Thinking about that exceptional experience, what processes or behaviors actually made that exceptional? What was the difference? We all have experiences, and we probably all can think of 1 or 2 that just was incredible. We wanted to know all about that. What did it look like? Was it how you were treated? Was it the processes? Was it the behaviors? Was it the relationships? Was it the information? Was it the communication flow? So that gave us a lot of wonderful information. Next slide, please. This is the setup of the design team, multidisciplinary in nature with frontline staff, frontline leaders, ancillary department stakeholders, and patient-family representatives. The insights and ideas from the PFAC were brought back to their patient and family innovation unit, their design team meetings. And then those teams met weekly. Some of them met every 2 weeks, but they had a core group of people who were talking about this every single week. And you'll see it spans from reviewing the data all the way to spread. So next slide, please. This was where we began. We challenged frontline staff, and I talked to many of them that were in the innovation units, and we asked them to really challenge the things that they did. Where's their mailbox? So this came from my middle schooler who we were driving one day, very busy street, and he saw something that I hadn't seen before. And he said, Mom, what are all those mailboxes doing in the middle of nowhere? And I said, what are you talking about? And he said, well, look at them. They're all in the middle. They're right in front of the fields. And I looked and I said, oh, no, that mailbox belongs across the street to that house. That mailbox belongs across the street. And he said, well, why would anyone want their mailbox across this busy street? You mean to tell me they have to actually cross the street to get their mail every day? And I said, well, it's not about, that. It's about the, there's a white truck and they have a window and they don't want to back up. And so he said, you know what, Mom, if that was my house, I would say, I want my mailbox in front of the house and it's for you guys to figure it out because it really is my mail. And I got to thinking, you know what it is, their healthcare, right? So next slide, please. And then afterwards, and then you can just kind of keep clicking. Afterwards, I got to kind of researching, and certainly enough, there's a lot of issues with mailboxes across the street. And so, if the truth be known, next slide, please. It is still not changed, and it is in regulation that they need to be installed on the right side of the road in the direction of the carrier's line of travel. So really, it's just a perfect example of, are we built around our own efficiency and productivity, or are we built around the value to the people that we actually are serving? Next slide, please. PDSA, I won't go through this, but we definitely did a lot of cycles. We failed fast. If we decided on a project that was not working, we failed fast and we moved on to the next idea. Next slide, please. Communication flow is very important. We had on the left side of your screen is the patient representative communication flow, and on the right side is operations. So out of that design team, the representatives from operations would bring it all the way up to hospital senior leadership, and our patient family representatives brought it all the way to the statewide Patient Family Advisory Council to share our learnings. Next slide, please. Here's a couple of pictures from our innovation units. And here's some of our examples of success. It was really hard to pick out a few, but some of our hospitals. So Bridgeport, you know, they had a surgical unit that they participated in, a large surgical unit. I believe it was 32 beds. They wanted multidisciplinary team rounding. They couldn't move the surgeons to do it. It was right in the middle of it. But he said, you know what, I'll give you a PA. So to this day, the surgical PAs are leading teams, going in and having conversations with patients. Bristol Health, and you could see their HCAHPS results. Bristol Health looked at bedside report, communication with nurses through that whole process, and it was much bigger than just a bedside report template. It was all of the way that they communicated with patients and families throughout the day. But nurse communication went up 21%. Incidental overtime, believe it or not, came down 62%. And that was one of the big pushbacks. We really don't have the time to do it. It actually saved the staff time. It was a really big success for them. You could see what they did at Children's. They did a particular point of contact. Patients and families were very confused. There was multiple people that were in the care team from a physician perspective, lots of different consults. They created a singular point of communication, which was a big win for those families of those kids. Greenwich Hospital created a chance to chat. Everyone takes 5 minutes from their day and builds a relationship with patients. Built upon not what's the matter with you, but what matters to you. And they actually went into the 99th percentile for the inpatient unit, which was huge for them because they are higher than maternity now, which we all know maternity is a really happy place. So they were ecstatic. Next slide, please. Lawrence Memorial did extraordinarily well in this process too. They actually designed a bedside report with having a conversation with the patient. So the other nurse that they were giving a report to was silent. The conversation was with the patient, and that was the full report. So Mrs. Jones, you came in on such and such a day, you had belly pain, we took you to CAT scan, which was negative. Conversation with the patient, other nurse just listening. It was a big culture change, but they really got a lot of bang for their buck on that. And they're up to 85% from 62, which they were struggling with. Middlesex, phenomenal. New medication teaching materials. Their data was strong. And they really hit hard on side effects, which was brilliant. Really great, strong team there. Stanford did a no-pass zone where no one can cross and ignore a light. A light, a call bell, is a reactive perspective of care. We wanted to be proactive, so we wanted to catch patients before they even put on their bell. That's where the care partner model came in with geographical assignments. Their fall rate was reduced, which was phenomenal because they were geographically assigned, the care teams, and their call bells were reduced by 76%. Getting less reactive and more proactive. UConn John Dempsey, you can see they had an impact on their falls with injury, which decreased 68%. And that was really perfecting the process of rounding with intent. and really engaging patients and families in simulation. So it was the patients and families that were educating the frontline staff on a variety of different things on that unit. So next slide, please. Cohort 2 was launched this last November. Next slide, please. Another 8 hospitals, so we have 16 total innovation units up and running in Connecticut. Next slide. Innovation is a state of mind. Next slide, please. Lots of keys, organizational commitments, probably on top of mind, but I'm going to go over just a couple of them here. Next slide. Lack of buy-in from employees at the front line can really put a wrench in your system, but lack of buy-in from senior execs is really critical and will really doom the project from the start. And those middle managers, those frontline leaders are absolutely key to generating those enthusiasm. Next slide, please. This is very typical. This is what we see. This is what we saw in the innovation unit staff. But what was not typical, next slide, please, was that we had about 2.5% resistors. Now, these are the folks that dug their heels in. Typically, they're not talking to you. They're talking to everybody else in the break room. We had to sit down with them. We had to engage them. We did separate education for a lot of the frontline staff, trying to bring those resistors along, and we had them at the table, which typically with resistors, you know, people kind of avoid. We wanted them with us, engage with us, elbow to elbow. Next slide, please. So this is the last slide, and this is sustainability. So understanding the why is absolutely key. People will not gravitate to anything that they do not know why you are doing it. So very important. The me, they rule. So the me, they rule is number 1 and number 2 critical for success is people have got to understand why it is better for the patients and families that they serve, but as well, it's got to be better for me. Meaning, it can't increase my workload, it can't increase my stress, I've got to be able to get out on time, it can't affect my work-life balance, I've got to be able to do all the work that I do. So it's a win-win. Better for the staff, better for the patients, eliminating the old process. People will always jump back to the place of comfort. In the old form, the old way of doing it, as soon as you have a glitch in the new process, you've got to eliminate that old process, and you've got to show that it works through data. So next slide. So happy to take any questions. I'm sure that you guys have been talking back and forth in the chat room, but I invite Mary Cooper and Donna back in.
Great. Thank you, Ellen, and thank you, Mary and Donna. This was extremely interesting, and I appreciate you taking the time to share this program with us. There have been a few questions, so I'll start with this most recent one posted by Charlene. What method was used to get resistors to the discussion table?
Okay, Mary and Donna, you want to take that one?
Yeah, Ellen, why don't you take that one?
Sure. Great question. So let me just tell you a quick overview. We had a hospital that really struggled with this. So we went offline and we built, I teach emotional intelligence, and I love it. I'm very committed to it. I think it's foundational, right? The other IQ. I built really a change management course for them. It was 90 minutes. It was mandatory for all innovation unit staff. And I talked them through the why, the good for me, good for they. And we had lots of great discussion, and we were able to turn them around. So you really have to concentrate on that. Mary, do you have anything to add as far as that goes?
No, I think that resistors are always there for every project that we do. And to be quite honest, if we get to 97.5% of the people, we probably just assume that at some point the resistors will either come along or they'll leave the organization. Yeah, I'd be thrilled if we got to 97.5% with every group.
Mm-hmm. So we like to say, maybe it's time to take your excellence elsewhere. And so there were people who really, not a lot, but people who just didn't really feel comfortable engaging patients and families in the way that we were asking them to in full partnership. And so, they chose that this was an environment that they wanted to work in, and that's okay.
Mm-hmm. I think that's important to keep in mind when you're doing work like this, is sometimes that you will need to agree to disagree, and just understand that not everyone is going to be able to come all the way up with you.
Yep.
And
Another
Lindsay, it's
question.
Mary. I was just going to say, I just see that Harvey Hellerstein added on a question to this. What if the resistors are managers? So that's incumbent upon us as leaders to make sure that they are giving the message that we want them to give. We know that every single organization has a hidden culture or hidden curriculum or hidden, sort of behaviors, and surfacing those and making sure that people are adhering to the, to the way we approach it, while allowing honest and candid conversation, I think is what one has to do. We can't have the folks undercutting what the organization is trying to do.
Mm-hmm. Great point, Mary. Another question that came up: how are significant changes managed in facilities using Epic or other other technology like Epic?
So I can,
So
yeah,
can I
go ahead.
ask a clarifying question? Yeah, let me just, it's Mary. If I can just ask a clarifying question. If I'm accurate, you're referencing Epic, the IT system that we use for electronic health records.
Electronic.
And I do think that there are times that we use our electronic health records to change behavior by doing things like forcing functions where, you make people fill in a blank rather than go on to the next screen, or you only give people certain choices, et cetera. But I would say to you that change management and changing culture is really better done through people-to-people interaction, more so than relying on technology by itself, because I have yet to see the organization that doesn't find a workaround for technology that gets in the way of doing what they want to do. And so I think it's more about building up that change management and the outcomes of the culture by, sort of how we interact with our colleagues.
Mm-hmm. Interesting. Thank you for that. I think the last question that I wanted to end on was regarding COVID and our current climate and crisis right now. And I know that this team is presenting at the PFCC conference and going to dive a little bit deeper, but I was just curious if you could give us a quick 30-second, 1-minute kind of synopsis of what it's been like over the last couple of months for these innovation units.
And,
Sure.
and Ellen, if I can go first, and then maybe you can come in subsequently. So because I noticed as well, a question here is, how did you interact with patients and families when they weren't in the hospital? As Ellen talked about in the beginning, we're a high reliability state. We've rolled out high reliability approaches and principles in all our hospitals across the state. And over the past 10 years that we've done that, fundamentally, we're about safety. First and foremost, keeping people safe, because if people have unsafe experiences, they are not going to have good experiences with patient and family-centered care. And through much deliberation, we, like most other hospitals in the country, had to make very difficult decisions about whether patient and family members would be permitted to come in and visit family members, or whether patients could have family members. We discussed it with the community of persons with disabilities. We discussed it with all of our clinicians. We discussed it with many of the hospitals, discussed it with their PFACs. We made a very difficult decision to restrict visitors, because at the time, as COVID was advancing, we just had no idea how we were going to keep people safe when we didn't even have enough personal protective equipment for the staff who were in there. And we just couldn't put people at risk. So we've gotten back over the discussion and the decision many times. I don't know what'll happen when we have our next surge. We will have another surge, I'm sure. What'll happen in that next surge, because we now are allowing patients, families, and patients in. The OB patients were involved in those discussions, and whether we allow doulas, whether we allow partners, and et cetera. And there was no right answer. I still don't think there's a right answer until we know much more about COVID. And I can't wait to tell you, sort of our findings and our discussions in the fall when we present our session about patient family centered care during COVID. Ellen, I don't know if you want to add anything. I see we're at 4.
No, that was perfect. That was exactly right. So we're looking forward to speaking about it in September as well.
Mary, it's Donna.
Wonderful.
I think innovation did play a role, not only from internal but external patients and the healthcare staff using the iPads, for instance, so that people could communicate with their families, at least for short periods of time. So I think the whole change process helped people think out of the box.
Well said, Donna. Thank you so much. And thank you, Ellen and Mary, as well. We really appreciate, again, you taking the time to talk to us today and talk to us in September for the PFCC conference. If you have any other questions for our presenters today, please feel free to email me at lindsay@pfccpartners.com, and I will help get your questions answered. This workshop has been recorded, and we will share the link to everyone who registered for today's workshop as well. So thank you all very much. Have a wonderful weekend, and take care of each other.
Thank you, everyone.
Lindsay.
Thank you, everyone.